Welcome to Healthcare Rounds. I'm your host, John Marchica, founder and CEO of Darwin Research Group. Today, we're exploring a topic that doesn't get nearly enough attention in health system strategy conversations, and that is how pediatric care is organized and delivered. My guest today is Danish Qureshi, founder and CEO of Zarminali Pediatrics. And today, we're going to talk about the inspiration behind Zarminali, the structural problems in pediatric care delivery, and what it takes to build a new model designed around children and families. So, Danish, welcome to Healthcare Rounds.
Thanks, John. Great to be here.
Let's start with your story. Just a little bit of research I did before our conversation today. I noticed that your daughter's illness is what maybe ultimately inspired the founding. So, talk to us a little bit about the origin story of your organization.
Yeah, absolutely. So, Zarminali is the third healthcare startup that I've been a part of, and really the one that is most personally informed by the situation that my wife and I went through about 2 years ago when our daughter was diagnosed with an autoimmune disorder, and the difficulty we had navigating the healthcare system around pediatrics to get her the type of care that she needed and ultimately get her healthier. We're lucky that we reside in Chicago and we've got access to great health systems here. However, despite having those great health systems and despite eventually being able to navigate to the right kind of specialists for her care, what we found was that many of those specialists worked in their own silos. They didn't coordinate with each other. There was no coordination back with our primary care pediatrician. And really, the burden of care coordination fell on us as parents. And though I have 15 plus years of healthcare experience, I still found it extremely difficult and stressful to navigate. And so we as parents were left in this scenario of not just being under immense stress, but also being left with this immense feeling of guilt as our daughter's symptoms didn't improve as quickly as they should have, of saying, gosh, we were just failing her. And we should be able to do a better job than we were doing. And that's where it was really the light bulb moment for me of saying, this just shouldn't be how pediatrics works in the country. That, again, if someone like myself with many years of healthcare experience is finding it this difficult to navigate, I can only imagine what the average family has to deal with when their child has any form of complex issue. And so that's what informed the foundation of Zarminali Pediatrics, is saying we can do better when it comes to pediatrics. There was an opportunity to bring together all of these different pediatric specialists under one umbrella and ultimately deliver really great care for families that doesn't have to be as stressful as it was for us in our own personal situation.
You said light bulb, and I'm always curious, was there like a single point in time where you were just said, I'd had it? Like, was there one thing that really pushed you over the edge and said, we need to find a better way?
I think it was this a particular moment where we got referred to another specialist after going in circles for months and picking up the phone and calling that specialist's office only to find the first available appointment was another 6 months away. When we were struggling in that particular moment. And the reality is that had we known, we should have ended up with that specialist in the first place. And so our daughter could have gone better much faster had we just gone to the right person at the right time, had there been more of a care team approach versus the way we were just sort of bouncing around. So that was really the moment where I said, this just can't be how it is. It shouldn't be like this. And I kept thinking about all the things that we had done at my previous companies, particularly the last one, which was a company called LifeStance Health in the behavioral health space, where by just bringing together all of the different specialties under one umbrella, creating a seamless approach for the consumer to be able to book, but also creating a care team environment for the providers to be able to truly collaborate with each other on an individual's patient case. That's the formula here to make an impact across the country.
So I'm wondering, what is it that makes pediatrics different? your story, we could say a similar story with my frustration with trying to get care for my mom, for example, or for other people. But for me, pediatrics just feels different. So from your perspective, especially with your experience in healthcare, what made this different? And I guess maybe a follow-up question to that is, early on, did you have some vision about what pediatric care could look like or should look like?
Mm-hmm. Yeah. So I think there are a lot of similarities in with pediatrics to many other specialties in the country, of just the stuff we hear about on a regular basis, that the healthcare system is broken, it's difficult to navigate, et cetera. So there are many things that are not unique to pediatrics. I think what really stands out with pediatrics specifically is that the actual patient, in this case, the child, is not the one seeking out the care, is not the one booking the care, is not the one navigating the system. It's actually the caregiver, or typically the parent or someone else. And that process where the patient can't always advocate for themselves, I think is something really unique to pediatrics. The other part that's unique is it's something because children, in a good way, tend to be much healthier than what you see with the senior population, where a lot of our focus in the healthcare system today goes. They tend to get ignored, or because it doesn't show up as much of a cost item, maybe on a payer's P&L, it tends to be an afterthought than something that is driving a big portion of spend in the country. But the reality is that the behaviors that are learned at a young age and the care that a child receives or doesn't receive, it carries through the entirety of their life. And I really believe that a lot of the ballooning costs that we see across all of healthcare can be traced back to the source and addressed when the individual is still a child. And if you get it right then, you can have a generational impact over the next decades on controlling costs and improving outcomes for people's lives. So, again, I think there's a few things that are really unique to pediatrics. Ultimately, one of the things that is really frustrating, and again, in my last company, we saw this in the behavioral health space too, was because most of the outpatient or the independent practice groups that exist today in pediatrics are very, very small and don't have an ability to really orchestrate much of this sort of more complex care. They also are because of that, they end up being the lowest reimbursed specialty, or one of the lowest reimbursed specialties across all of healthcare. That creates a problem of individuals going through medical school and residency. They don't want to opt into pediatrics because it's not compensated well. It's not as attractive. That then perpetuates itself in a shortage of providers, a shortage of people focused on pediatrics. So again, a lot of different things that are building on itself to say that what we see in pediatrics is unique, even if there are similarities to other specialties.
Why do you think, and maybe the answer is self-evident, but the parents are often in that care coordinator role, which is what you were describing, that frustration. Why do you think that is the case? Like, in other words, why hasn't pediatrics in general done better with this, with care coordination? And why is it so much on the shoulders of the parents?
You really, our sort of diagnosis of it, and the reason, going back to kind of the second part of your last question, why we're trying to build this differently, is what you've ended up seeing is a high degree of fragmentation across all of pediatrics. And that's not just primary care pediatrics, where you do see very small independent practice groups out in the community that are delivering phenomenal care, just phenomenal pediatricians that love what they're doing. They got into it for the right reason, but ultimately they're working in these sort of small groups, and thousands of them across the country. But you also see these specialists that are pediatric focused also are broken up and fragmented pretty significantly. They either are employed by the hospital systems, and you have this barrier now between the hospital system and the community-based providers, which the majority of pediatric care is delivered out in the community, or you see specialists, they may be in a community-based or independent practice group, but they're employed by the other half of their specialty. And what I mean by that is they may be a pediatric cardiologist, as an example, but they're employed by the cardiology group, not by the pediatric group, or an allergist employed by an allergy group, not by a pediatric group. Ultimately, what it creates is a need for this constant referring back and forth between different groups. Every time you have a handoff like that, something gets lost. Either a family doesn't follow through, certain information on that child's case is not passed through, but something gets lost in the process. And that friction really makes it difficult for families and ultimately leads to worse outcomes for their children. So our approach and what we're trying to build is the first true national multi-specialty group just focused on pediatrics, where anything and everything that can be delivered outside of the hospital system is done under one umbrella, one brand name, one place that a family can go to where they know they can get any need handled, as well as layering in urgent care services, as well as 24/7 telemedicine, so that when a child wakes up and they're sick and they can't wait for that booked appointment a week out, they can get into an urgent care, or they can get access to their group in the middle of the night when they wake up with a cold. Those things are really important to reducing stress and reducing friction across the system.
Really, what you're trying to do, I just want to understand this. In my mind, there's kind of like the first model that you described, that health system, you know, fill in the blank children's hospital, right?
Mm-hmm.
And there are a lot of those across the country. And then you have these smaller pediatric groups, like I'm thinking when my kids were younger, where we used to take them. What you're saying is you're trying to create something that really has everything under one roof, from the basics, vaccinations, taking care of your, colds and basic things, all the way to more complicated issues.
Mm-hmm.
And then where you would come in is being able to coordinate, especially if that care needed to happen outside of your walls. Is that right? You're trying to get all that.
That's correct. Yeah. So as much of it that we can deliver within our care setting, obviously being outpatient, we want to deliver that ourselves, because it makes sure that the providers are working on the same team, sometimes in the same office, they're coordinating on the case together, and the family is feeling a very seamless experience. But there are absolutely more complex or acute situations that do require bringing in or sending that patient out to a hospital system for things that can only be done inpatient, or requires a specialty that is so unique or so specialized that housing it in the community doesn't make sense. And so that collaborative arrangement with children's health systems, or health systems generally in any community, is going to be important for us to ensure that our families are getting the best possible care. But again, where possible, we will deliver those services ourselves in an outpatient and community-based setting. And again, we believe that not just improves outcomes, but significantly reduces the stress on families in that process.
So help me understand the business model a little bit to get under the hood, because this is truly something different from my understanding, at least what you're aspiring to become. Are you focused on payer partnerships? Have you gone out to employers to do any kind of direct contracting? Like, what is the business model? Because you got to get paid, right?
Yeah.
So how are you going about doing this and able to achieve your goals?
Yeah, so we're taking this in a very phased approach. And in the first phase, we're keeping it very simple. This is commercial fee for service. This is classic, covered by your health insurance on an in-network basis. There's nothing sort of complicated or sophisticated about it. But we really view that as being the foundation of what we're building, and purposely so, because we want to have margins that are sustainable and that are not reliant on unique partnerships with a payer or a health system or whatever reimbursement vehicle is needed. From there, though, what we hope to do is be able to expand into value-based care agreements with payers in whatever given state around managed Medicaid programs, where we're already demonstrating exactly what they're hoping for, which is by being able to deliver all of these different specialties under one umbrella and be able to more comprehensively take care of that patient, we are ultimately controlling costs for that payer and that specific member, and also delivering better healthcare outcomes in the process. And that's sort of the holy grail of what any value-based care agreement is structured on. And so we are not rushing to value-based care because, again, I believe that you have to build a sustainable margin and foundation on commercial fee-for-service. But from there, we will start to selectively contract on the value-based care side. The third phase of it for us is we do believe on a direct-to-consumer basis there is an opportunity for additional premium services that are not typically covered by a payer in any arrangement, where we can start to have a special arrangement with our families that are part of Zarminali. And that does not mean a membership-based or concierge model that creates a lot of restrictions or narrows the number of people that can actually afford the service. But we want to be as open to as many people as possible while also offering a premium level for individuals that are looking for a different sort of level of care that they can receive from the practice group. So that's the third phase. That's farther out, but we will start to build towards that. Regardless, even from day one, on a commercial fee-for-service classic basis, having a sustainable margin profile is really critical to us.
So back to the number 2 on the value-based care side, because that was actually my next question that I was going to ask you. And you had mentioned like state Medicaid potentially.
Mm-hmm.
That feels like kind of a capitated sort of arrangement, right? Where you're going to sort of per member per month. Do you see the opportunity to do like ACO like arrangements in pediatrics? And the reason why I ask that is, we're talking about like the older population and focusing on them, and those have been, when I think about CMS, it's like you're either going into an ACO or you're going into some kind of Medicare Advantage program, right? That's how they're trying to capture that value, but then also control costs with those two different models. Do you see there being a possibility? Because before you answer that, I seem to remember here in Phoenix that there was a pediatric ACO. I didn't learn all that much about it, but what are your thoughts on that kind of, that budgetary model in pediatrics?
I think that there's an opportunity there. That's not something that we're spending a lot of time on. I think for us, more classic value-based care one-off arrangements with managed Medicaid programs is essentially what we're building towards. And we'll only really be doing that in selective states where the reimbursement makes sense. We're not going to be rushing to do that in every single state because not every state has payers that are excited or willing to do that, nor is the state Medicaid are the state Medicaid plans funded to an appropriate level to sort of justify it. But there are many states that have put pediatrics at the forefront of what they're thinking about, and they're both funding the programs appropriately around Medicaid as well as more on the cutting edge of what it means to explore value-based care. So, again, we're going to do it as a much more of a one-off, state-by-state, payer-by-payer sort of approach rather than what you're describing as the kind of comprehensive ACO model across multiple practice groups in a single geography.
Yeah. So what is it about, the theme that I'm thinking about with what you're trying to do is integration. And so are there elements about pediatric care that makes, or a different way of saying that, or what are the key elements that actually can make integrated pediatric care work?
Yeah, I think it's first figuring out what are the things that are most impactful on that pediatric population, and what are the specialties that you absolutely need to have if you want to ensure that you're providing great care to as many families as possible. And so the way that we've done this is obviously the starting point was primary care pediatrics. Urgent care is a very obvious add-on for being able to create extended hours, and eventually they will launch the 24/7 telemedicine piece. But from the specialty perspective, it's what are the pieces that are being referred out to the most today, where that friction is being created, and closing that gap by pulling those providers in-house. So the first things for us are launching speech, occupational, and behavioral therapy under kind of our umbrella, co-located in the exact same clinics as our primary care providers are working out of. On the medical specialty side, we're looking at allergy and derm as the top two that we're referred out to on the most frequent basis. And then from there, we'll keep going down the list as our patient population grows enough to justify pulling in other specialists. So we have a pretty large presence in Michigan as an example. And because of that, it allowed us to employ a neurologist as part of the practice group. And so you start to see, as your groups and your patient base grows larger and larger, you can start to pull in more of these specialties that you can't do when you're small or you don't have the density that you're hoping for. And again, if you go back to the fragmentation problem, if you're a small independent group of maybe 2 to 5 pediatricians, you'll never be able to employ a neurologist because it's not something where there's enough demand from your patients to be able to fill their caseload. But when you build larger groups, you can start to do things that are a lot more unique.
So are the majority of the physicians, are they employed, or are you more on a contract model, or is it both?
100% employed. So we really believe that it's important for everyone to be underneath the same umbrella and working together on the same problems. And being employed is one way that you can accomplish that.
So for me, as you expand, I would think one of the most difficult things to accomplish is consistency,
Mm-hmm.
right? And I think about like large health systems that start expanding their footprint. How are you going to address that, or how are you already addressing that? And how do you, what built-in mechanisms do you have to maintain that consistency for the future as you expand?
Yeah, so the consistency and quality of care that we're delivering across the country, that is something that we talk about on a daily basis. So the two very practical ways that we've done this is, first, think about the operational side, and then secondly, think about the clinical side. So on the operational side, the entire team is built around a limited set of 10 KPIs that ultimately we believe drive consistency in operations and quality of care that our patients and families experience, regardless of what city, state, or clinic they're walking into. So being really unapologetic about, we're focused on these are important, and
these are your KPIs.
These are
right?
our own KPIs. That's exactly right. Now we have other KPIs that are more, well, if you hit those 10 and you do it consistently, what should you see on the output side? And the output is you have really high patient NPS or kind of review ratings. And so for us, year to date, we're obviously a couple months into the year, we have a patient NPS of 100. Last year, we ended up for the full year above 80. I can't remember the exact number, but our patient NPS score was phenomenal. And it was really attributed to the fact that we're just unapologetic about, here are the 10 things, this is what we care about, and we're going to talk about this on a daily basis to ensure consistency across the country on the operations side, which when you walk into a clinic, the look and feel, the experience you have, a lot of that is kind of the non-clinical part. On the clinical side, which is obviously the more important part, our chief medical officer is leading the charge there to ensure that there are very specific quality measures that we are talking about and measuring across the country not just to be able to deliver great care today, but also to be able to get us to that next phase that we talked about of value-based care and being able to show that we're doing this on a regular basis. But she's and her team are in the process of building out their entire clinical analytics suite and ensuring that we're measuring the quality and the outcomes that our families and their children are experiencing.
Danish, is there a role for partnerships? We do a lot of work with health systems. That's kind of like our sweet spot here at Darwin.
Mm-hmm.
How do you look at your relationship to some of the larger IDNs out there?
Yeah, so we view health systems as a really key partner in what we're trying to build around the country. Pediatrics, even in a children's hospital example where many of the things that I'm describing may already be delivered within that children's health system, the reality is that 80% of pediatric care is delivered out in the community. And so, though these children's health systems may have everything kind of within one house, similar to what we're trying to do out in the community, the reality is they're only able to meet the patient demand of a limited amount of the country. And so for us, we really view ourselves as important extenders out into that 80% of care that's delivered in the community to be able to deliver the same kind of rigor and consistency and quality that you're getting in these health systems, but delivered in a community-based setting. So that's really important to us. But by doing that, it is still important that we maintain and have these collaborative relationships with health systems in our communities, because we need to send them many referrals for patients that we're unable to deliver the more complex or acute care in the outpatient or community-based setting. And so having that collaboration is really critical for any patient and their family. And so we look to, in any community that we enter, start to build those relationships with the local health systems, either on a formal basis in a contractual way or on an informal basis. And so we always welcome any and all conversations, both inbound and outbound, as it relates to partnering with health systems in our communities.
Danish, everything sounds exciting, sounds rosy, sounds the future is bright. So now I have to ask, what's keeping you up at night? Where are the struggles that you see as you're scaling and growing your business? What are the biggest challenges?
I think the biggest challenges are the same thing that anyone trying to run healthcare at scale experiences, which is, to some of your questions earlier, the consistency of care delivery when you're not doing it in a single location, but you're doing it across multiple locations in multiple states. That is one of the biggest challenges, and it always keeps you up at night to make sure that consistency is delivered and the quality is there. I think on the growth perspective, I wouldn't call that a stressor, but it is probably the thing that keeps me up at night the most, because I'm constantly thinking about how can we go faster, how can we grow larger, and how can we meet the needs of more and more families around the country. I mean, though we're in 10 states today, that's not the limit of our ambition. We really want to be delivering care across all 50 states, whether that's in person or virtual. And we want to be able to say that we're meaningfully touching the lives of millions of people, both the direct patients as well as their caregivers, parents, family members. And so that sort of goal of being able to reach these millions of individuals is probably the thing that keeps me up the most at night, but more of a kind of positive, motivating reason than a stressor.
Sure. So let's go look 3-5 years down into the future. What does success look like? How would you describe that?
So in 3 to 5 years, what I would describe as success is that we are delivering care in all 50 states, 30 of those states in person as well as virtual, 20 of those states virtual only, and it's just based on the population density. So the top 30 states account for about 85 to 90% of the US population. So those are the ones that we want to have physical presence in as well as virtual. And for the remainder, we want to be able to have virtual presence. From there, saying that we're offering a comprehensive suite of specialty services across every one of those geographies. So again, on the therapy side, speech, occupational, behavioral; on the medical side, allergy and derm to start, but hopefully that list grows much longer and we're able to go a lot deeper. And then we'll have started by that point signing some of our value-based care contracts, and we'll start to be able to meaningfully demonstrate that we're impacting the cost curve and the quality of care in any one of the communities that we're participating in. And I hope by that point we've also nailed the premium service offering as well. So that's really the 3 to 5 year vision. Where it goes from there, I think the sky's the limit. Every week there's a new interesting conversation that comes up from some partner who's reaching out about a new idea and really wants to tap into how can they better deliver care for the pediatric population. So the reality is that vision 3 to 5 years from now could be much bigger than what I just outlined, but that's sort of our current ambition.
I meant to ask you this as an initial question, but tell me about your name. How did you come up with the name?
Yeah, so Zarminali Pediatrics is the name of it is derived from a young girl's name from the Pashto language, which is from the Afghanistan region. And what it means is something that's more precious to you than gold. And it's a very beautiful name that clearly represents the relationship between a parent and child, which is any parent would say that their child is more precious to them than gold. And for us, we want to extend that feeling into the care that we provide for our families and for that child. Is we want to treat them like they are more precious than gold to us as well. So that was kind of the meaning behind it that really resonated with everyone when we were starting the company. The other piece is my daughter's name is Zarmina, and because she was really the experience we went through with her was really the inspiration behind the company. It just made perfect sense.
All right. Well, before we wrap up, I'd love to do a little lightning round. So just some quick pops into the head.
Okay.
Say either a word or a phrase. First one misconception people have about pediatric healthcare delivery.
That it's an afterthought of the overall healthcare system, that it is not a big enough place for anyone to spend time focusing on improving, that there's bigger problems in the senior population or other specialty areas. And so, don't put attention to pediatrics.
A leadership lesson that you learned along the way.
I think probably the biggest lesson that I'll call it relearned with Zarminali is the importance of building out a really high quality talent team from the very beginning, and also being very unapologetic about maintaining the bar at a very high level. I think as you scale and you move quickly, there is a tendency to say, I just need people. And so I start to lower the bar on expectations of the talent that you're recruiting in. And this has been something I've learned across my entire career and has been a great reminder here at Zarminali is you have to be unapologetic and very unwavering about holding the bar for talent as high as possible.
I think you just answered my next one, but I'm going to ask anyway, because I know you've done a few of these. Most important trait for building a healthcare startup?
That's absolutely, I'd say the number one, but I guess the nuance there in response to that question is you also have to recruit people in that are not just great talents, but that they really are inspired by and believe in the mission. That this is something that is as meaningful to them as it was to me at the start, that they feel the pain that families go through and they want to solve that. That is really critical. And I think something beyond just having a high caliber of talent is really important.
One healthcare innovation outside pediatrics that you're watching closely?
I think the obvious answer that probably anyone and everyone will give is all the innovation around AI, whether it's directly in the delivery of care, whether it's supporting providers in making their lives easier, whether it's in the back office, whether it's in interfacing with consumers and how they get access to care. I think that is moving so quickly. We're a young company. We're like just barely over a year old, and already the things that we were thinking about AI at the foundation of our company and the decisions we're making around where and where not to introduce AI, that has already evolved in the last year, because the things that are available now just are moving at a breakneck pace. It's quite honestly hard to even keep up with all of the different pieces of innovation that are happening, and building a tech stack that is cutting edge when the edge continues to move so rapidly out. That's a real challenge, but it's also very exciting.
Well, Danish, thank you so much for today. How do people get a hold of you or to learn more about your organization?
Well, they can go to Zarminali.com and look us up, and I'm always happy to take any inbounds from interested folks that want to talk pediatrics.
Well, thanks again. Thanks so much for joining us today and for sharing your story and your vision for improving pediatric care. It's very inspirational. I really appreciate it.
Great. Thanks, John. It was great being here.
And thanks to all of you for listening. If you enjoyed this episode, please subscribe to Healthcare Rounds wherever you get your podcast. And I'm John Marchica. Until next time, we'll see you next round.